This podcast intro, songs AI. It's on YouTube and Spotify. You can use your ears or use your eyes. It's 30 minutes randomized.
Hello and welcome back to another episode of 30 Minutes Randomized. I'm your host, Steve Wimmer. With me today is a LinkedIn friend, Victoria Alvarez, who is the Vice President of Operations at Clinsearch. Victoria, welcome to the podcast.
Thank you, Steve. Thank you for having me. Excited.
Yeah, absolutely. A fellow Floridian, someone who gets to complain about heat for 9 to 10 months out of the year. Victoria, if you can orient folks just a little bit to like, what is Clinsearch? What are you doing as the VP of Operations there so they understand where your answers are coming from?
Sure. So I like to call Clinsearch a clinical trial support network because we work with independent sites. We don't own or operate any of the sites. We partner with them and we kind of serve as like a fractional team for the sites. So we handle a lot of BD, budget and contracting. We help them with regulatory. We kind of try to start up, as quickly as possible. We also have a QC team on board. We handle feasibilities. So just kind of a little extra support to the sites when they need it. And as operations, I pretty much handle everything at Clinsearch from legal to accounting to, getting studies started, just organizing the whole team, managing the CRM. And I'm also kind of like a mentor for new sites. So I kind of, take on one or two sites every year and kind of lead them through, what it's like, because they're naive.
Very cool. Yeah. Having someone who's done it before in pretty much any area of life is really helpful. So I'm
Yes.
glad to hear that someone with some experience is helping folks kind of on board into clinical research because we need more sites doing good work. All right. So the format of the show, if you're a new listener, I have a randomization wheel with some questions for Victoria. I'm going to pull it up. We're going to ask the questions randomly and see what happens. I am sharing my screen now and we are going to races. About half of these are like operational questions for you. The other half are very random, and we're going to get one of those to start. So I am always curious what people are up to when they are not working on clinical research problems. So what was the last event you went to that required a ticket? This could be like a movie, live theater, music, just something where you had to like pay to get in.
My goodness. That's just showing me that I barely get out.
Uh-oh. You're like, well, 1994, I went to.
Yeah, I'm like always at the gym or like at the beach or the pool. I want to say, I don't know, like Universal Studios, I think. Does
Ooh,
that count?
yeah, that absolutely counts. Those tickets aren't cheap. And
No.
you get to hang out with 10,000 of your sweatiest friends and wait 2 hours for rides.
As a Floridian,
do-
I'm smart. I went in the winter.
Oh, very smart. Are you a ride person? Did you ride rides?
I don't like roller coasters, and thank God neither does my 12-year-old, but we definitely liked all the other rides. We went to Epic too, so the new park. It was fun.
Oh, yeah. Sick. I live in Orlando and still have yet to go. I know they did an expansion to the Harry Potter universe, which I'm very excited about as a fan of the series. Cool. All right, Universal. Let us know next time you're in town. We know a million people work there. You can go for free. All right, cool. Let's head back. We're SeaWorld people, or at least we used to be.
Yes. I
Haven't
like
been in a while. Oh gosh, I hit the wrong button. Something's happening.
Oh no.
Yeah, no problem. It doesn't matter. I also don't edit the shows very much, so this is absolutely going to show up. Here we go. All right. So I've been asking everyone on the show this because I'm curious and because it's so wild to hear answers from people in different spots in clinical research. But how are you using AI in an average day? And you can answer this professionally, but I'm also curious, like what you're opening up and what you're doing day to day.
I mean, I honestly use AI a lot. My boyfriend's super like techie, so he put me onto it like very early on, and he like
Okay.
pushes me to use it. So I mean, I use it for like so much. Just even drafting some emails sometimes, getting information. And I also we don't have a CTMS like a regular CTMS. We have a CRM with Monday.com, and Monday.com they actually have a lot of AI agents. So I've been able to actually like dive in when things were a little bit slow in the research world. I kind of like revamped all of Clinsearch's operation on Monday. And so I kind of use that, and it's very helpful. I use it every single day. I even use it for my tasks to organize my task. And there's a lot of automations like built in, and I built a lot of the automations. So I want to say I use AI like a ton.
Awesome.
I'm contributing to the water depletion. I'm sorry.
Yeah, I don't know enough to respond to that, but I suspect that there's plenty of other things that are using water in our world. We'll be okay. Come at me in the comments if you disagree. I want to just ask real quick a follow-up because I don't have a ton of experience in the site world, and by that I mean I have zero experience in the site world. I've kind of lived exclusively in patient recruitment land. And my understanding is like a CTMS is kind of the system of record for what's going on in the study, and it's how you get paid. So if you're not running with a CTMS, like how are you kind of logging visits and doing invoicing and
So
stuff like
our
that?
sites, we don't own the sites. So again, our sites do use a CTMS.
Okay.
And then it's kind of hard because again, if to leave them independent, I can't be telling them or forcing them which CTMS to use. I've demoed all the CTMSs. I know how to use all the CTMSs. I help them with their CTMS and I help them with their billing and all that. So kind of what we do is when we do QC, we kind of know information from their CTMS and then we plug that into Monday, which Monday is, you can make it into a CTMS if you want to because it's a CRM and it's completely customizable. So that's how we kind of run things.
Got it. Okay. That makes total sense. All right. Thank you for diving a little deeper there, which is like the first time I've gone on a deeper dive on the AI question. So hooray. All right. This one is from your LinkedIn. So I was scrolling through some of your posts just to see if there was anything fun to talk about. And you posted a while back about an issue where folks with COPD were getting an interstitial lung disease diagnosis specifically to kind of game the system around payments. And, you wrote that it has kind of a negative impact on the veracity of the data. And like, there's all these down funnel things. So I'm curious just to start, and maybe we can go from here, but like, if this is happening in the clinical data, how are you making decisions about what data is even trustworthy?
Yeah, it's really hard. Down in South Florida, pretty much all of the senior citizens, they're on Medicare Advantage plans. And a lot of those plans, it's all value-based. So the higher risk the patient, the more they get paid. And so we were noticing, we used to be with like a huge HMO kind of managed care plan, and we were doing a COPD study, and almost every patient had interstitial lung disease, and that was one of the disqualifications. So when, talking to a lot of the doctors, they were like, oh, they don't really have interstitial lung disease. Like, so they would kind of write notes and stuff. And I was a little bit appalled. We don't work with that site anymore. But I know it's rampant. I know it happens everywhere. It happened with, I think, United Healthcare, which is one of the largest. So that's why I always say like AI is great. But data in, bad data in, bad data out. So it is very challenging. And that's where you kind of have to go like on a case by case basis and kind of really look at every patient. So it definitely makes recruitment, challenging. Not all physicians do that. Not all clinics do that. So I think it's very important to align yourself with, people that are very ethical, like that's a really big challenge that we have, ethics in research, especially in South Florida. I know we have a bad reputation. So, my advice is, try to be with the most ethical, partners that you can, and really have to kind of sort the data like on a one-to-one basis, because sometimes you just can't rely on that huge data set.
Okay. Yeah, that makes total sense. And I think, so it sounds like you're hoping upstream you can just work with folks who aren't going to have the incentive to maybe fudge the truth a little bit. If you wake up and you are seeing this, and you're in an indication where this might happen, and I'm sure there's other indications like beyond COPD where this happens, and you just have to work with the data set, are you then saying, all right, well, we can't apply AI to it because at a foundational level, it's a little bit suspect and we have to treat it one by one? Is that kind of the only solution?
I mean, so far from my end, from what I've seen, that's basically what we would have the coordinators, work with the PIs and the doctors on a one-by-one basis and really review, the scans, really review everything. I'm sure there might be AI that can probably start detecting that stuff from CTs and stuff like that as we get more advanced. And it's probably gonna not allow these groups to do those unethical things because, the AI is gonna pick it up. Like they really don't have the interstitial lung disease or things of that nature.
Yeah, got it. Okay, well, thank you. And we might be circling back to talk a little bit more about South Florida because there is a question on the wheel about it. All right, this is just a random icebreaker, but I am curious. So you're offered $3 million, but for the rest of your life, whenever you get angry, a mariachi band appears and they play mariachi music for 30 seconds.
It's gonna
Would
be
you take,
fun how they're gonna be able to get into my car because it seems like that's what I'm
listen,
angry.
it's magic. Okay, so would you take the money?
Of course, absolutely.
Absolutely. So, all right.
Arriba!
You're taking the money and then now you're driving down 95 and someone cuts you off and all of a sudden there's 4 guys playing music in your car for 30 again. You're fine
I
with
think
that.
it's gonna be a very good anger management tool, I suppose.
That's true. That's true. Especially if you don't like the music, it could be a negative reinforcement. All right. Well, I will work on getting you the 3 million wired and I'll talk to a genie about the mariachi band so that we can make sure that this comes true for you. And maybe it'll be a new show on Netflix. All right. We are moving along here rapidly through the wheel. Okay. So you alluded to this, but I wanna circle back because I don't know much about site world, but I have heard this that South Florida does have a reputation, like you said. How much of that is earned, and how much is a couple of bad actors causing a massive problem for a bunch of good sites?
I mean, I've been doing research a little bit over 10 years now. And since I started, I've been hearing the Miami, trend. But it's kind of like it's hard, but at the same time, Miami is a huge health hub. We have so many retirees. Another big thing that people don't realize is that we have such an influx of Cubans, and a lot of Cubans were medically trained. So we have a bunch of foreign medical doctors that work as coordinators. We just have a lot going on. So it's kind of like they hate us, but they need us because I don't like. From what I've seen, sometimes once I got a feasibility report, it was like the questions and they didn't realize, but on the Excel spreadsheet, they had put all of the answers like on another tab. And it was like probably like 200 answers and 90% of them were like in Florida and South Florida. And I was like shooketh. So like down here, there's like a research in every corner. So I
Yeah.
definitely think the good outweighs the bad. Like I've worked with amazing high quality sites. We still do. We have some sites we've been working with for 10 years and these people are the most ethical, good business partners. But that there are horrible actors, yeah, there really are, and from our side, we kind of see it right away, like when they're not good at paying, when they're not good at being responsive, when you get them to study and then they kind of disappear. My guess is they're not going to be very good with the sponsor either. And the thing for us at least is we cut them very quickly and we move on. And I've heard, really crazy, insane stories. Like during COVID, there were doctors enrolling duplicates and, but again,
Yeah.
I definitely think the good outweighs the bad. It's just they get a lot more attention, the bad.
Sure. Does it come up? Do people ever bring it up directly, like when they're trying to award studies? Or is it more like, oh, we're hearing about this in the hallway at a conference? Or like, are you having professional conversations where a sponsor's like, hey, we noticed your address and we've got some concerns?
No, I've never encountered that ever when applying for a study or at a PSSV. Luckily they don't kind of, talk about that stuff. It's definitely like hallway talk, conference talk, when you're on LinkedIn, when you hear certain things, but it's never stopped us. The majority of our sites are in Florida. I want to say like 60% of them are in Florida. And while there is a lot of competition, none of that ever gets really talked about at the PSSV. You gotta have to prove yourself too. On top of that, you do a bad job the first time, like you're not gonna get repeat business. And this is a repeat business kind of gig.
Yeah, for sure. Fool me once, shame on you. Fool me twice, shame on me. And I think that makes tons of sense. Yeah, I'm a Florida apologist in general. Like I like our culture and state for the most part. So I wanted to hear how you're thinking about it as someone who's in it and probably knows people are like saying bad things behind your back. But it sounds like there's so many more positives and the magnetism of like, this is a place where you do want to have sites. It's the challenge is more just like kind of weeding through. And that's where reputation, like you can't buy reputation. Like it's earned over time.
It takes a lifetime to build it and a second to ruin it.
There it is. Words of wisdom. I keep forgetting to press stop sharing. So we've got like the wheel dominating the screen. It doesn't really matter because we make up the rules and everything's fine. Okay. So I know a lot of sponsors they're trying to like systematize site selection, and they've got these spreadsheets and they've got these formulas like, oh, it's spitting out these 10 sites. What's something you think is true at a genuinely great site that would never show up on a site selection spreadsheet?
The patient doctor relationship. That's gold. That's solid gold. I work with some doctors that see thousands of patients and they give them their cell phone numbers. That is
Okay.
a PI that gets to enroll. They know their patients very, very well. Like they don't even, some of these doctors are like just geniuses. I don't even know how they remember all of this stuff. And they know their patients so well. And they probably can enroll better than any eye machine ever can, because just off the top of their head, they're like, oh, I know this guy qualifies, this guy, this guy, this guy. This will be great for this guy. And then they talk to their patients and it's like a shoo-in. Like there's really not much discussion because they build such good rapport with those patients that those patients really trust their doctors. And I don't think that's something that, like, how do we quantify that, on a spreadsheet,
Yeah, what shows up is like, oh, this is how many patients are in my database. And like that relational
And the
tr
motivation too, that's another thing, like the intrinsic motivation to want to do research, because sometimes there's some good doctors or some good practices. I've worked with a practice that had 100,000 patients. They couldn't enroll to save their life, but that wasn't their main, business. Their main business was making money off their medical center. So they weren't as motivated. Then there's some doctors that they just really love the research. They love being at the head of medicine. They believe in, pushing it forward. And those are your like superstar enrollers, so that's another thing. You don't know that on a spreadsheet or not. The other side might look great. They have 100,000 patients, but that's why when people tell me numbers, sometimes I'm like, okay, like show me
Yeah,
what you got first.
that's really interesting. Now, it seems like this might be like those are in the category of maybe like embedded sites, not necessarily like a built for purpose like research facility that only does like I know you've posted some about the PE backed kind of like monolith sites.
Research standalone, like we work with kind of like, I want to say like half embedded, half research standalone. And those research standalones, it's the same thing. Those doctors, they have those research patients for like a long time. Sometimes they do different studies, they do screening studies. And a lot of it is like the way that you treat the patient, the way that you educate the patient, that builds that trust over time. And also the motivation to enroll, to do well. There's no better enroller than a physician, when they talk to the patient, it's a different ballgame.
Yeah. So it sounds like, I mean, you like came alive here, like you're really passionate about it. Is there a way for that to be quantified, like so that these sites that have these great relationships show up closer to the top when, sponsor XYZ is running their algorithm to recommend sites, or it's so relational, it's never going to show up in something like that?
I think what we need is more back to meetings, like back to investigator meetings in person. Remote is great, but it's nothing like going to the site and seeing the site and you see the movement at the site and you see the PI engaged. Like typically when you go to a site and the PI is nowhere to be found, you know, unless he's very busy with other patients, that's why I feel like, sponsors have to come on site, and that report that the CRA should matter a lot. Like they have to have that information somewhere plugged in, like, hey, this is a great site. I love this energy. PI is wonderful. Patient room is stacked, because you don't really see that remotely.
Yeah. Oh, that's really good. All right, it's time. Get on a plane.
That's
Or
right.
pay to put everybody else on a plane and get them all to some location. It doesn't have to be Tahiti, folks. Like we can have a productive meeting anywhere. All right, cool. That's really good. Thank you. We only have two more. We are flying through the wheel today on a Friday afternoon.
We're quick with it.
Okay. I saw you post, and we were at this conference, but we didn't meet. I was there as well. You talked about going digital at Research Revolution. And you've also posted about coming from the paper world where like randomizations were in envelopes, and if they were crinkled, they resulted in a finding. There's kind of a trend that's not so quiet going on of sites that were early adopters of eSource backing off of eSource and kind of returning to the world of paper, at least for that function. Like they're still digital sites, they're tech forward, but at least for source, they're like, hey, we're not sure this really works. Do you have strong feelings here? Like what have you experienced?
Yeah, I've actually been pushing my sites to go digital, and I myself, like, I'm on site a lot. So while I do operations for the network, I really believe in being on site because that's where everything is. How can I help you if I'm not there? And I've played around with the e-source on a study. I've done the digital ISF, and the thing is, it's good idea. We're just not 100% there yet. Like with the ISF, with the investigator site file, a lot of the work that the coordinators now have to do is redundant because, like, for example, like, and I don't want to shame, but there's two major players in the big ESI. I'm not going to say any names, but
Got you.
neither one of them really has like the best signature functionality. So what ends up happening is that sites are still creating documents on paper and they're just scanning it. So it's like a sophisticated OneDrive, and that creates a lot more work than just having to sign it and file it away. They still have to sign it and file it away, but now they have to scan it, upload it. Sometimes you have to classify it. Like it just, and then you're talking about coordinators who are just already such on a time crunch because they're with patients and they're, doing the source and they have to upload data and they have to have queries. So now you're just adding and compounding more of the work, and it's not really saving them any time. It saves the sponsors time. And that's why these companies are probably making so much money, because that's where the money comes from. But for the site, it's what I've noticed is that digital is really becoming a bit of a burden. And so I can imagine that's why a lot of them are going paper. By the source side, I recently worked on a study, huge sponsor, one of the largest sponsors in the world, and they were providing the e-source through a vendor. Again, I don't want to say any names because I'm not going to badmouth anybody. But the site, in the SIV, they were kind of assured that they were going to be bumper rails and the e-source. And they were somehow allowed to misdose, a patient because there wasn't that bumper rail. Like, it's very important when you create a
Mm.
source. Not only is it the CRF that goes into the EDC, but you want to have like little tips of the protocol in there. Like I put sometimes things in red letters, like make sure you're doing this. So it really takes someone really knowledgeable. You really do have to read through the protocol and put those little bumper rails so that when the coordinators, just with patients every day, they don't make that mistake. And the site was relying on the sponsor to have those guardrails up, and they didn't. And I think the sites are just not used to, because it is customizable, the e-source, but they're just not used to it too. It's a little bit of a learning curve. So I think because then they get dinged, then they're like, oh no, let's go back to paper because this wouldn't have happened with paper. So I think we're just in that transition. I think digital is inevitable, but we're just figuring out the kinks, I think.
Okay. Yeah. I want to hone in, and maybe the answer just is the answer, but like it sounded like at first you were describing not necessarily it's a functionality issue. Like the thing works for the most part as described, with bumper rails notwithstanding. They're supposed to be there and they weren't. But the thing working as described still doesn't fit quite into the workflow as it actually exists at the site level. And that's where some of the tension is. Is that like a fair?
I would say so. Yeah, I would say so. Plus, it just kind of gives them anxiety because, then they really are forced to do everything in real time, which they should be doing anyways. But, and then they're just used to having their little chart, and it's kind of easier to like read through and go back and forth when you're with a paper chart than when you're in a digital system. You kind of like, I think you get kind of ADD and you forget to go back. And I just think it's kind of like, teaching an old dog new tricks. Maybe the newer generation of coordinators will love digital and they'll be like, how did you ever do this on paper? Kind of like back then they were doing copy paper. But I think for some of the seasoned coordinators, it's definitely a learning curve.
Okay. Yeah. I've seen people, there's an emerging conversation that adoption is like the main thing, not necessarily innovating more or fixing the problem or like changing the technology. It's just getting the technology to be used more. I don't know. We'll see.
Sometimes it's a
Thankfully, I
little
don't have to
cumbersome.
ever. What's that?
Sometimes it's a little cumbersome too. Like I think
Yeah.
these systems can be a little bit cleaner, more intuitive, but then again, it's very complex work. So it's not like Facebook or Instagram.
Yeah. You can't swipe right to randomize or whatever.
No.
Cool. All right. Well, the future is now and the future is coming. Hopefully it'll be a good one for research.
Or the
We
future
are
gonna
down to our
come.
last question. I'm excited about it. I don't remember what it is, but I'm excited. Well, I do remember what it is. All right. You got to plan a birthday party for an entire class of 6-year-olds, and you have to hire either an experienced study coordinator, a CRO project manager, or a ClinOps lead from the sponsor team to plan and execute this party. Who do you trust?
I think either one is going to be amazing. All of those roles, they need to be super organized. They need to be on the ball. They need to be personable to get the job done. So, do any of them have a part-time as a clown, maybe?
um, no, that's only reserved for salespeople in SaaS. They're all part-time clowns. Just kidding, all my sales friends. It's me. I'm making fun of myself. Okay, that was a very diplomatic answer. I had hoped that you would dunk on somebody or elevate maybe the person at the site level just out of solidarity, but very diplomatic. And you're
All those
probably
people
right.
work hard. They all work hard, really. I think everything in the research cycle is just, we're all like just working like maniacs every single day. Like it's a hot potato. We got to do so much. Like, sometimes you get your bad ones, but for the most part, I've been super blessed to work with like brilliant people. I really think they elevate me so much. Just this industry is full of super smart people and super capable people.
Yeah. I think I've had that experience too, like working across sponsors and CROs and sites that there's very few people who I'm like, ugh, how'd you land this job? It's all people probably working more than 40 hours a week and doing excellent stuff. Weird that everyone is working more than 40 hours a week and there's still a lot of people looking for work and saying you can't find it.
It's sad.
Interesting.
Yeah, I know.
Cool. Well, we did it. We exhausted the wheel and we, I think, had some good conversation. I really appreciate you taking the time and sharing kind of your perspectives. Any final parting shots? You can talk to between 12 and 17 people who listen to this podcast and say one thing about clinical research. You don't have to, but if you do, now's your shot.
One thing about clinical research, just, get it done, work hard, be blessed that you're working in an incredible field. It's fulfilling. Hopefully you're making a little bit of money and you're meeting great people. I love it. I never wanted to work in the medical field. My family all worked in the medical field. My mom owned, medical businesses, and I always said I was going to go into law. So I used to be a paralegal, and then my brother created this company and he brought me along, and I've never looked back. I love it.
Right on. That's awesome. If people are trying to get in touch with you or Clinsearch, what's the best way?
LinkedIn. I'm always
All right.
on.
LinkedIn, the platform of the gods. All right. Thank you so much again and have a great weekend, Victoria.
Thank you, Steve. I appreciate you having me.
Minutes randomized.
Thanks for listening to 30 Minutes Randomized. If you enjoyed the show, please feel free to like, subscribe, review, or share it with a friend. Until next time, I'm your host, Steve Wimmer, reminding you to stay random.